Good evening, everyone. We are so excited that you have joined us again for another installment of our monthly webinars. Tonight, we're going to be talking about long COVID. We have an amazing panel of experts. I mean, really, like these are the people you want to hear from, as you know, because you registered for this webinar. I want to give everyone a second to join. And I just want to remind you that you can follow us on social media where we actually advertise all of our webinars. We are now on LinkedIn. If you want to give us a follow there, Columbia Children's Health. We also put the webinars that are coming up there with the link to register, and we'll be putting a link to the recap of this webinar on there as well. So definitely make sure to follow us on social media. We also have a podcast that we piloted this past fall with tons and tons and tons of really good information. And just to mention very briefly that we actually have the dates for our next two webinars. If you want to mark your calendars, we have April 17th at 6 p.m. We're going to be talking about the care of formerly premature infants. We're going to have amazing people from the NICU and all of our doctors who do NICU follow-ups after babies are discharged from the NICU about all of the aspects of their care, and they're going to be catching us up. And then we also have May 14th at 6 p.m. where we're going to be talking about asthma, the latest in treatment, and the particulars of treating asthma in urban populations. So we hope you join us. With that, let me go ahead and introduce our amazing panel of experts that we have this evening. So first we have Dr. Erika Berman-Rosenzweig. She is a professor of pediatrics and medicine. She's also the director of the Adult and Pediatric Pulmonary Hypertension Comprehensive Care Center, as well as the vice chair for clinical and translational research in our Department of Pediatrics. We also have Dr. Joshua Milner, who is the director of the Division of Pediatric Allergy, Immunology, and Rheumatology, and the chief of Allergy, Immunology, and Rheumatology Services at Morgan Stanley Children's Hospital. And Dr. Melissa Stockwell, who is a professor of pediatrics and population and family health and the chief of the Division of Child and Adolescent Health. She's also the director of our Division of Child and Adolescent Health and the clinical service here at New York Presbyterian Morgan Stanley Children's Hospital. Welcome. We are really so grateful. You all are extremely busy people. You have so many things going on that we're really just excited to have you, and we want to hear from you. So I figured we could start because I know you all have very different areas of expertise and different journeys to how you came to study long COVID. So I wanted to really start by asking you to tell us and share a little bit of that journey and how you landed on studying long COVID in particular. So maybe Erika, I'll start with you.
Thank you. I know what Melissa is going to say, but basically we kind of forged a team together when in the midst of the pandemic, we were realizing along with the rest of the world, frankly, that there was first of all, the pandemic and then what was identified as the long COVID or long lasting effects of SARS-CoV-2 infection that was not resolving in the usual course that a viral infection would. And so we actually came together around a research grant that we'll talk about a little bit later called the RECOVER study, and felt it was very important to be involved so that we can really write the history and figure out why these long-term ramifications were happening and how we could impact that in the future for children. So I'll pass it over to Melissa.
Yeah.
Thanks. We're all laughing a little bit because Josh and Erika got together first, and then they said we need someone to lead this and run this, and then they talked me into doing it. But I'm actually really glad I did. So my background had previously been on vaccination and then on surveillance for a respiratory infection. So at that time, I had done a lot of COVID work, but from the infection point of view. And as Erika said, there had been this sort of misperception in the beginning that children didn't get COVID, and we had been fighting for a very long time showing that they did. And there was this sort of same misperception that kids weren't getting long COVID. And so at that time, when NIH was putting together this research initiative, RECOVER, that we're a part of, different teams across the US were putting in applications. And the reason why I wanted to join was, one, to answer that question, but that I also, and we all felt that it was really important that the children that we take care of at Columbia and Presbyterian and in Washington Heights and in the Bronx were reflected in this national study, and that they weren't going to be left behind, when sort of and not represented. So we also felt there was sort of this mission to make sure that the kids that we care for were going to be part of the population that was going to help answer this important question.
Yeah, I love that. What about you, Josh?
So you can throw me under the bus, Erika. I mean, I definitely did the lion's share of twisting twisting Melissa's arm to run everything. In no small part. So I actually arrived at Columbia just a couple of months before COVID started, and it was like a welcoming present from everyone. Because of my clinical and research interests as an immunologist, it just became front and center, whether or not the immune system had anything to do with COVID, which I guess, spoiler alert that it does, then that was something to obviously pay a good bit of attention to. And also because of being of the types of patients who we see with immune disorders and with immune regulation disorders, being able to control your immune system, in addition to being able to not being able to fight certain viruses. We've actually seen folks with many of the features of long COVID well before COVID existed. So it's something we've seen after viruses in other settings which would get brought to our attention. And so that's why a combination of patients being referred and of the obvious overlap with what we already saw, that it became an important thing to pursue.
Yeah, perfect. And I also, Josh, arrived at Columbia a couple months before the pandemic, and yeah, it was an interesting time for all of us, definitely. Melissa, I want to go to you and start by asking, what, to the best of our ability, is long COVID? Like, how are we defining it right now?
So I'm mute. So there are different definitions, particularly between and a broad definition I'm going to talk about and they're different between sort of CDC and World Health Organization. What they have in common is that it's basically symptoms that are prolonged after a COVID infection. But those symptoms can be new, so they could occur after the infection is gone. They could be continuing, so some of them, obviously, like the loss of taste and smell, might happen during infection, then they continue. They could be exacerbations of chronic conditions or recurring symptoms that come back for someone had those symptoms before. They often do come and go, so that's one of the hardest things, I think, is that's relapsing and remitting piece of it. And then particularly for definition of long COVID, is having an impact on the child or the adult's life. In terms of time frame, the CDC uses 4 weeks. So if you sort of have symptoms, it's sort of been 4 weeks since infection. The World Health Organization uses 12 weeks. So that's why some people might hear sort of 1 month, 3 months, but that's sort of a little bit of a different of the definition piece. And a key piece is that it really can happen after, it can be moderate or severe infection, but also can happen after a mild or even asymptomatic infection. And you can imagine that is what makes it a little bit hard to study, because that it's not necessarily something that happens with infection and continues. It can happen, a few months later. And so how do you sort of make that tie together to really understand this is coming from the COVID infection?
Yeah. So symptoms need to start within 4 weeks to 12 weeks of.
It's not within, it said at least it's the after. So within or after. So it's the prolonged piece of it. So for example, if someone has a COVID infection, say, this is the easiest, and they still have fatigue and it's been 3 weeks, then often we'll say, okay, well, that may just be the normal window. And Josh, as an immunologist, could probably tell you, that's actually can be common. We said after flu also, right? That there's it can take about a month after a certain viral infection just to sort of feel yourself again. But when you're getting past that month and those symptoms are continuing, or they're starting after, now you're in this sort of 4 week, 12-week period, that's when we're thinking more about long COVID, thinking about them being prolonged symptoms.
Yeah, very glad I asked you that question, because we are, really important, right, to differentiate between what's considered still the primary illness versus like now we're talking about long COVID. I do have a follow-up question, but I want to remind everyone who has joined us, first of all, welcome. We're so grateful that you're here, but also you can send your questions at any moment during the conversation this evening through the Q&A. We'll try to incorporate them as we're talking, but we're also going to save some time at the end for questions. So again, feel free to send in your questions. So I guess the other thing that I was wondering if you can weigh in on, Melissa, is how many children are impacted by long COVID, again, to the best of our ability to understand, like what really is the incidence of long COVID after you had an infection?
And that's something we don't have a full answer yet, but actually one of the things that we're hoping to understand with the RECOVER study. There have been a lot of studies on long COVID. The issue is that based on how they're put together, they're ending up with very, very wide prevalence. Say, for example, 2% to 72%. Probably it's going to be more like 10 to 20%, we think. But even if you talk about being at the lowest, so even if you say, okay, it's 2 to 10%, that's many, many millions of children who are affected. And the CDC just did a seroprevalence study, and they think 65 million kids in the US have had COVID. So if you even take 10% of 65 million, that's 6 million. And whether it'll be that many or not, even if it's half that, right, that's these kids can be severely infected. The other thing is I did actually look this up because when I was giving a talk on long COVID, is that we consider something to be a rare disease when it's under 200,000 kids. And we're talking about millions. Now, granted, not all those kids will have long COVID forever, but I really want people to understand the magnitude of this, that there are a lot of children who are very severely affected. And again, we're affecting, it's terrible when an adult has long COVID. When a child has long COVID, they really can't do all of the things we need them to do as children, right? We need them to go to school and to socialize and do all of those things. And they're really not able to do all of those things.
Yeah. What's that? I want to, Josh, I want to go to you and ask you about underlying mechanisms, but before we move on, I wonder if you can give people a sense of symptoms and how this presents a little bit, because I think we have sort of this vague notion of someone who's a kid who's really tired. But aside from that, what else should we be thinking about in terms of?
There's a lot, constellations of symptoms. And again, I think I'm going to keep talking about the RECOVER study, because that's actually one of the very, very key things that we're assessing, is sort of what do symptoms look like. So I think, clinically what people are seeing is obviously the fatigue is a part of it. Some kids are seeing, some people are seeing chronic cough, for example. But the things that I think have been more surprising to me in sort of studying long COVID are some of the things actually that Josh mentioned when he was indicating those other post-viral infections. So we are definitely you're seeing kids with basically dysautonomia, so problems with their autonomic system. And what it looks like is they end up with POTS, or, postural tachycardia. And Erika's going to talk about this a little bit more, but they basically get very dizzy when they're standing. We see kids who, after they have either physical activity or mental activity, which again, not like very strenuous, even like we would consider to be mild, the next day they're just, flat out, just completely on the couch. And again, I think Erika will talk about this a little bit more. There are some GI symptoms. So some of the kids have, GI motility issues. Headache is something that's actually another thing that's common. Sometimes we see different rashes. You can see like basically every body system, there's kind of different pieces. And then I think you want to talk a little bit later about the mental health aspects too. So there's definitely an increase in, we think there's an increase in depression and anxiety as well. And I mean that in comparison to normal adolescent population. So we definitely obviously see that children and adolescents, there's sort of a baseline of all of these things that I've mentioned. And that's, I think, one of the reasons why it's been hard to study is if you just look at kids with COVID or long COVID and you don't compare them to other kids who have been in the pandemic in the last 4 years, it's hard to tease apart sort of what's from the COVID and what's from just sort of being a child. And that's one of the things that RECOVER is doing.
Yeah, no, definitely. And it's a wide range, just like COVID itself can present with a wide range of symptoms, and it's definitely going to have to be a retraining and rethinking for us who are general pediatricians and are sort of encountering this very vague, wide-ranging symptoms. We definitely, of course, and that's the reason we're doing this, need to learn and be ready to look out for those symptoms. Josh, I want to ask you, as I said, what do we know about underlying mechanisms? What causes long COVID, the biological processes behind it? What do we know? Where are we in that understanding?
So, look, it's an incredibly difficult question because we certainly have plenty of papers describing things that look like they've gone wrong in folks who have long COVID. That doesn't tell us what's causing the long COVID. And so I do want to sort of separate that pretty much the only things that we know about long COVID for the most part are associations, not causations. And I think that's an important distinction to make. I'm going to rattle off a few things, but I guess what I want to be careful about is suddenly everyone's going to go, oh, I need to go, buy an eye of newt and some other thing because somebody found something that was an association. It is important to make that right from the outset. It really is largely going to be treatment studies that are going to really tell us what is actually causing things. And right now we don't really have that so much, certainly not in kids. There are some genetic studies that those might veer more on the causation as opposed to just the association. But those genetic studies, again, spoiler alert, there's a long time before we can figure out what they have to do. They don't obviously point to anything. So what are the things that have been observed in people who have long COVID? One has been disruption of the blood-brain barrier in those who have brain fog and the such. And that disruption appears to be that the blood vessels are not behaving the way they should and are letting things through that shouldn't be let through. And that blood-brain barrier is basically what separates your brain and the functioning of your neurons and just what's coursing through your bloodstream. And for the most part, we're protected from many, many, many things by this barrier between your bloodstream and your brain. And when that becomes porous, when it shouldn't be, that can cause any number of cognitive symptoms. And so at least it's an observation that's been made that the blood-brain barrier is disrupted. That doesn't tell me that that's causing the brain fog, but it certainly hints to that it is possible that the failure of those blood vessels in the brain is not working. And the reason why that finding is also important is that globally, and again, with the grain of salt, not just in terms of the associations, but associations with what, right? How do you define long COVID is going to make probably a difference in terms of what's causing. And there could be different causes of different forms of long COVID. So, but for certain definitions of long COVID, one of the associations is with overactivation of something called the complement system, which then ends up affecting the way that blood vessels function. And so not just at the blood-brain barrier, but it could be globally, there are issues with the inside of the blood vessels and what they let through and what they don't let through, and actually even inflammation in the blood vessel itself that then causes many issues. And actually, as I'm sure Erika could describe, there definitely are a number of issues that can happen related to COVID, setting the blood vessels on fire, as it were. That's what MIS-C actually in some ways absolutely is, the multi-system inflammatory syndrome associated with children. That's in its extremis, but it seems to be a general pattern that inflammation in the blood vessels and therefore poor performance of those blood vessels, poor of what they're supposed to be doing, of keeping certain things in and delivering certain things to where they need to go, that is it looks to be a strong association, and it could be that some particular driver of that is actually then what can cause that. And why that happens in some people and not others is not particularly well known. Again, the genetics may help us with that. But that's still something we're trying to understand. But that just very concretely is something that people have observed. Unfortunately, it takes pretty advanced testing to see these kinds of things. And it's not like I can go and run a test on a person and say, oh, you've got long COVID, because I can see that your blood vessels aren't working well. We're not quite there yet, but that will be something for sure to pursue. Another broad area, which is important and is not unrelated to the blood vessel problem, is that it seems clear that the folks who end up having long COVID tend to get other viruses coming back to life after they have their COVID infection. So it's not bad enough to get COVID, but what COVID does is actually alters your immune system's general policing of the viruses that are inside us all the time, like chickenpox, right? People who get shingles, it's because they were not able to continue to control the chickenpox. But other people who get sometimes swollen glands or swollen lymph nodes when mono comes back. Though it's one of the things that can happen. As we've learned, mono can lead to lots of different issues, even when it comes back, not just that first infection, but years later, something can happen to your immune system, like COVID, and that then allows mono to creep back, other kinds of herpes viruses that are sitting dormant in our bodies to creep back and cause the problems that those viruses can cause. Has nothing to do with COVID, except that COVID let that virus wreak its havoc, right? So that is going to be, that's an important thing to keep in mind. That's been an association. It doesn't explain everything, because there also are folks where it's been demonstrated that COVID itself is persisting in different tissues in some people who have certain versions of long COVID. Those all may be related to each other, right? The person who is going to have mono come back when they get fatigue when they get COVID may also be the person who can't clear their COVID as well out of certain tissues either. And as the result, damage could end up happening, let's say, to the blood vessels. That would be a narrative that you could come up with. Again, though it's still not, the causation is not proven. But it is certainly something we see in folks who have long COVID, is the reactivation of other viruses. We call reactivation. Does not need to lead to a full-blown, you didn't have to get shingles for that. You can have it in many different ways. And it could be also the persistence of COVID in certain areas that then causes a response. The last thing I just wanted to point out is it the immune system that's causing the problem? And the answer is it could be. And we have plenty of evidence that the immune system is active. But I don't know that calming the immune system down necessarily would be the treatment, because it could well be that the virus itself causes damage, or the virus that it's letting reactivate causes damage directly to the tissue, never needs inflammation itself. As a result of the damage, you get inflammation because you're trying to fix the problem. And so I do want to, to say that it's not necessarily an autoimmune thing that ends up happening, even if you see autoimmunity going on. It could well be direct damage by the virus or viruses on tissues. And I think that's, again, just as a concept, an important thing to keep in mind as well.
Right. And I mean, an exciting thing to learn about, at the same time that we recognize that this is devastating for many children, right? The true incidence of which we're still learning, but definitely interesting to learn about. Josh, I want to ask you, as a follow-up question, I think when we think of risk factors for things like severe COVID, right? Like in the primary illness itself, we think of children who have or who struggle with obesity. We think of children with respiratory illnesses at baseline, right? Like children with asthma. Like we sort of have a sense, I don't know if it's necessarily like a totally complete sense, but we have a sense of the children who end up developing severe illness. Do we have any sense at all of children who are at higher risk of developing long COVID?
Yeah, I really don't think we have a great sense of it. From what I can say is that from most of the data that we've seen, it does look like children whose white blood counts drop the most when they got their original COVID infection. Those are the ones who might, first of all, might be more at risk for severe COVID, but also might be most at risk for the long COVID. But I don't know that we're seeing any other unique identifiers that are necessarily different than in the adults. And I think Melissa could speak to sort of the general demographic pieces, but it's not like we're seeing specific types of comorbidities that people have. I think that at least the story that gets brought to me the most is they were perfectly fine until this happened. I mean, that's what I see the most. And actually, that's also what I tend to see the most before COVID rolled along, when someone came with sort of these prolonged symptoms, is they were fine until whatever it was that came along, and then that happened. So I don't know that we really have as good of a sense there of what comorbidities or other things like that.
Yeah, I think that's true. I think that again, the stories I hear too are, again, had no other conditions. That is one of the things that is going to be studied in Recover. I know, and actually one of the key things is sort of what might be the clinical risk factor. So we do hope, in the next year, that we'll have more information, because I think that's what a lot of people do want to know that.
Yeah.
The risk and resiliency, right? Why do some
Absolutely.
children get this and some seem to be protected? So that's definitely a key question for Recover.
And as you mentioned, Melissa, just to sort of remind everyone that it really does seem to be happening whether you had a mild illness or a severe illness. There is, I want to ask you, Erika, about effects on the heart, but there's an interesting question that came in. I think on the one hand, we think about the incidence of long COVID in general, but the question that came in is about the incidence of a specific, I guess, symptom, POTS, part of the dysautonomia within long COVID itself. Do we have a sense, Melissa, I'll ask you, once we are diagnosing long COVID, do we have a sense of incidence of this dysautonomia and POTS in particular?
I don't think, unless Eric knows, I don't think we know what the incidence is. I would just say that it's looking, at least again, from the research, that it is, I would call it common, but is sort of one of the things that we are seeing more often, particularly, we're, obviously it's more kind of the adolescent, young adult population. And I think it's also in part what is most affecting kids, right? So if you can't stand, right, for a long time, like how do you go to school, right? How do you do all the things that you're going to do? So I think it's something, if you're seeing a child with POTS, I would be thinking long COVID. It's not only caused by long COVID, and obviously Josh can talk too more about, and Erika, about other causes of it, but it's something to be thinking about. And I'll let Erika take the cards piece from here.
Yeah, I can
Let's
tell you
talk
a little
about
bit.
it. Let's talk about the heart.
Well, let's talk about the heart. It's one of my favorite. So, I mean, of course, there was a lot of attention around what Josh mentioned, Miss C, early on and throughout the pandemic, and characterizing this sort of shock-like syndrome that led to decreased cardiac function. So I'm going to say one word about that and then move on to POTS. The good news is that in this, studies that have been done thus far, for the most part, it seems that cardiac function does recover with time, most often by 6 months, at least by echocardiography, that has normalized. So that's very, reassuring. Whether there are long-term effects, I mean, again, this is what's being studied in the Recover protocol, including for some children, later term MRIs to look for scarring in the heart and so forth. So, but so moving away from that specific, constellation of symptoms and of course, sort of a more acute presentation in, as Melissa and Josh have said, in the long-term, effects and long COVID, we're seeing, I would say, two major symptomatologies. One, this POTS, or postural orthostatic tachycardia syndrome, which can be seen without long COVID, but it seems that it's more common these days, and we're seeing it in specifically a lot more in the adolescents, where they're standing and it might not happen right away. You're going from sitting to standing, and within that first 10 minutes or so, there's a sudden jump in the heart rate. So by 30 to 40 beats per minute. And that does not feel, that doesn't feel right. Kids can get dizzy, lightheaded, and so forth. There is a way to test for it, which is to do literally a sit to stand test and, stand a child for 10 minutes afterwards to see if you can bring on these symptoms. But it can be, again, one of these subtle things that children, if they don't know about it, aren't necessarily going to bring it to anybody's attention. So, you kind of have to think about it if there's some other symptoms or other complaints that might suggest long COVID.
Yeah.
And the difference between that and orthostatic hypotension, the blood pressure is stable. It's truly the heart rate that's shooting up. And we think there's some autonomic dysfunction, whether somehow SARS-CoV-2 affects literally the nerves that are, that can account for this. We just don't know. We just don't know yet, but it is one of the more common findings, cardiac manifestations in children. And so again, I'll talk about this a little bit later, but as part of the RECOVER trial, we'll be doing that sit to stand test in the higher level testing, along with electrocardiograms and other tests.
Yeah.
The second entity that Melissa mentioned earlier is PEM, or this sort of post-exertional malaise, and that might not necessarily be cardiac, but it is sort of on that spectrum of children who are exerting, and then it may kind of bring back on the symptoms of COVID that they had previously, and it could occur that day or even the next day, and they can get muscle aches and pains. And again, children may not be inclined to report this or in touch really, unless you're thinking about it. You may not notice it at all, but it is something that we are looking into, and certainly has been an uptick in reporting of this constellation of symptoms as well. And those are really the two main ones. But again, we're going to be focusing on cardiac function and tachycardia, bradycardia, other, potentially for heart block. We'll be looking for these things because we really don't know the incidence of these occurring, for long COVID, but these are the things we're going to be looking for in RECOVER.
Perfect. Erika, I mean, that's so helpful to understand what you're seeing and what you're looking for. I want to make sure that I am understanding this crystal clear, because I am asked this question by families as a primary care pediatrician all the time. And it sounds like the carditis, the myocarditis, the pericarditis that had everyone freaked out very, early on, and understandably so. Now we've learned it resolves, right? Now we've learned a number of things about it, including that the risk is higher from COVID itself than it is from any sort of vaccine, but I digress. But what I'm hearing from you is that is not really a manifestation that you are seeing in the heart as part of long COVID. Am I hearing that correctly?
You are, absolutely. And thankfully that's reassuring, because I think that really was the focus for the cardiologist perspective early on. And then, we breathed a deep sigh of relief about, 3 to 6 months later, when we found, and even much more quickly, that the function tended to recover rather quickly. And so again, whether at the microscopic level there aren't long-term manifestations, we don't know, and that is why we're going to be doing some surveillance during this trial. But the major, clinical decline in function or pericarditis and inflammatory heart issues do appear to resolve from that acute
Perfect.
COVID.
So reassuring in all of this, right? For all of us, for parents, for general pediatricians on the ground for children. I mean, really reassuring. Now, Josh, there's a question that was asked simultaneously by two separate people, which I think is top of mind. What do we know about multiple infections with the SARS-CoV-2 virus with COVID, and whether that increases the risk of getting long COVID?
So I don't know that we have a solidly large database to tell us whether what happens most often. Do you get long COVID after that first one, and then You might get it again if you get another one. Are there some people who don't get long COVID until the second or third or fourth one? As much. I don't think we have as well collected of a database to say that we have that there. I would say, though, that I think that for the more significant long COVID cases, they happen with the first infection. And when people have it, and if they get infected again, in some cases it makes it worse. In some cases, it doesn't necessarily make it worse. And so what may matter is the order in which other things have happened. Like
Tell us
getting
more about that.
So let's say you get your first COVID,
Yeah.
you go off to college, you get mono by some miracle. And then, in that first semester, you had no problem with that first infection, you get mono, you have no problem with the mono. And then a year later, you get COVID again. And now you're reactivating that mono in a funny way. Then that could change the way things work. So it's not so much the number of times you get infected, but rather the various different factors that need to occur for long COVID to happen. Like I said, I think in most people, it's that first infection. They're already constituted in that way. But I think in others, it may well be that other things have to happen, including, by the way, puberty, because it's pretty clear that adolescents get long COVID more than, or certainly with different versions of long COVID more than younger kids do. And so if your first infection was when you're 11 and then your second infection was when you're 13, that could have a vastly different impact on what the long COVID looks like.
I love that you say that clearly. I don't know. And of course, everyone that I think about that I've, met either in my clinic or heard about who has developed symptoms that are concerning for long COVID, now that I think back, is a teenager. But I don't know that I had necessarily made the connection in my mind that there's something related to puberty. So thank you for making that click for me, Josh, because I don't know that it necessarily had clicked for me before.
Just to add, though, just to people doing the wrong shit, which is definitely true. I think adolescents probably are going to end up with a higher incidence, but we definitely see school-age children with long COVID. So,
yeah.
And I know that. So just
just to say that it happens more, and different
sure.
presentations even
during
during adolescence versus elementary school ages.
Yeah, absolutely.
Yeah. No, super interesting. Now, Josh, also while we have you, another question came in. What do we know about vaccines and whether they decrease the risk of developing long COVID?
So it does appear from multiple different studies that prior vaccination decreases the risk for someone who then gets COVID from developing long COVID. There have been less well understood and characterized studies that have, in people who have long COVID who get vaccinated, there may be a subset who get better. There may be subsets it doesn't change, and there may be subsets who get a little worse. It's a little bit messier there, but overall, as a population, prior vaccination does help. That's not a surprise because also in the adult population, those who are treated during the acute infection with remdesivir, with an antiviral during the acute infection, are also very clearly at lower risk for long COVID. And so, limiting that initial infection, whether through vaccination or with antivirals, does seem to protect later on. Whether they work once you have long COVID, I think that's for the antivirals, that's still a trial that needs to be done more carefully, and is going to be. And again, the vaccination afterwards, it's not as clear, but I do think, the other point to make about the vaccination is that effect wanes, which means that it is the vaccine working to prevent the infection in some way, and not that like your immune system just needs to see that vaccine once and then
it's done.
That it's all done. So I think that makes it more attributable to the vaccine, the fact that the farther away from it you are, the higher your risk is for getting long COVID.
That is very interesting and definitely very important for general pediatricians in our counseling, right? Because there's definitely vaccine fatigue. And I've started hearing from my patients, which I was very puzzled by at the beginning, but you sort of understand it now, or I'm starting to understand it, this notion of I've had enough vaccines. I've had enough, right? Like I've had 2, 3, they feel like that's enough. That should have done it. But I think now with this information is one additional piece of information that we can use in our counseling to say, you know, your protection against the illness itself and the prolonged illness wanes with time. And it's so important that we do vaccinate. And there was another question that had come in about whether there is any evidence that using pharmaceuticals in that initial infection decreases the risk of long COVID. And it sounds like there is some
Yeah, it's pretty frank. It's about a 30-something% decrease.
Wow.
In pretty well controlled and large studies. So you know that pharmaceutical treatment, you know, whether the problem is we don't have that nearly as much in kids because we don't tend to give it to them, except for ones with rare diseases, and there it becomes a little bit more difficult to disentangle long COVID from many other issues that are happening.
And you know, this is something I hadn't really thought about, but that was just asked in the chat. Post-treatment symptoms, and I wonder, you know, for any of you who may be familiar with this, but when you treat with remdesivir, dexamethasone, Paxlovid, et cetera, and we have a pharmacist that just put this question in the chat, is there any post-treatment symptoms from treating with those that might mimic long COVID?
I mean, the only thing is the rebound that people talk about after taking the viral after taking the antivirals. In some people, they get rebound acute COVID symptoms for the most part. But no, I'm not aware of anything there, and of whether being on a steroid regimen or anything like that puts one at risk. If they hadn't gotten the steroids, that they wouldn't have had the same problem, right? It's not. I don't think that seems to be fairly clear. Right. Erika, you may have. I'm sorry, you may have to say something.
No, I think it's the rebound isn't necessarily equate to long COVID. I think it's important for people to recognize that, right? So sort of a different phenomenon, but they can be intertwined, but they can also occur separately. So
great. Now, we have a lot of really amazing questions that are coming in the chat. Please keep sending them in. I'm going to ask a couple more questions, and then we definitely have time to tackle these. But Melissa, you know, for the general pediatricians who are on the line, and parents, because I think this is important in our partnership. When should we really be making a diagnosis of long COVID? Like a patient comes to see us and has a constellation of symptoms. Like when at this point should we make a diagnosis, and where do we send these kiddos?
Yeah. I mean, I think the first, and most important thing, and I'm glad you said with the sort of partnering with a parent, is this is real. So a lot of, I think, parents of kids with long COVID, it's been very hard for them, because I think that they go to their pediatrician and either patient doesn't sort of know what they're looking at, right? And I think that's part of the education, you know, or sort of are thinking it's, you know, it's not necessarily related to, you know, it's not, the symptoms are, you know, aren't what they seem to be. So I think that first, you know, you know, it is long COVID is real. Long COVID happens in children and adolescents and young adults and adults. And we should be thinking about and treating it like we do any other kind of disease. You know, I think that the AAP recommends sort of this sort of stepwise approach. So if you're seeing someone, it's been like 4 to 12 weeks after infection, and they're still have prolonged symptoms, or there are these new symptoms, particularly ones that now we've been talking about. So, you know, the fatigue, the brain fog, you know, dizzy when standing, you know, GI problems, you know, again, there's a whole different, you know, slow them, you know, prolonged headache, things like that. You know, first sort of assess how is it affecting their life, right? So is it affecting their going to school or other pieces? There's other healthy sort of lifestyle that we want to make sure, again, are not causing the symptoms, but can make symptoms worse. Or are they sleeping well? Are they eating well? Right? Like just like we would any another child with a chronic condition, we want to make sure those things, are okay. They've talked about, potential some lab tests. Honestly, there is, as Josh said, there is no biomarker, right? There's no test that we can say, do this test, and this says that a child has long COVID. And some of these kids actually will be serologically negative. So if you do serology, COVID is one of those viruses where not everyone mounts an immune response, the antibodies fade. So it's, again, really important not to sort of say, oh, I need to get an antibody test, or I need to know that there was a positive PCR, especially in kids these days. Many parents aren't even testing, right? At best, they're antigen testing at home, or often not testing at all. So again, you don't, it maybe they had an illness a few weeks ago, or a month ago, or 2 months ago, and they didn't test for it. But if you're kind of knowing seeing these prolonged symptoms are affecting their life, that's when you sort of want to, be thinking about, could it be long COVID? For some families, it may just be sort of watchful waiting, particularly if they're not, at 4 weeks, and it's not sort of going into, and it's not really affecting their being able to function and do things they do as kids. When we're getting to that sort of 3-month, and that's sort of the WHO cutoff, that's when you really should be thinking about sending them to a specialist. In some families, it might be earlier, right? So if you have a kid who really is unable to go to school, or is tired all the time, don't wait. Don't say, gotta wait till 3 months to make that referral. And there aren't actually that many pediatric long COVID clinics. So really, it's really about sending them to specialists. We do have groups of specialists at Columbia who have a particular interest in long COVID. And so, we sort of say, okay, based on the symptoms, like this is someone in cardiology, someone in neurology, someone, et cetera, to be seen. And I think that has worked well for families that we've taken care of. And then I think just talking about the PEM piece of it, so that post-inertial malaise, what's really important is this. It may look like people may think this is deconditioning, right? Like, oh, this is a kid who just needs to exercise more. That is actually not right, and actually is detrimental to them. So this post-inertial malaise, you can't exercise your way out of it. And oftentimes what will happen is that actually will make them worse, and actually, stop them getting better. And oftentimes these kids have something called like a push crash cycle. So they're feeling really good, they're going out doing all this stuff, and then they're crashing. And so similarly, if those kids, you send those kids to physical therapy, and it's not a physical therapist or a rehab medicine person who knows knows long COVID, or knows chronic fatigue. So this looks a lot actually like chronic fatigue. Then basically they're going to exercise them too much, and they're actually going to cause them harm. So again, you want to if in the case you're seeing a child with post-inertial malaise, you want to be sending them to someone who basically knows what the protocols are for exercise and for other things for those kids. The other thing is there are a lot of good parent groups. So Long COVID Families is one that we work with a lot in the Recover study. They have a lot of great wealth of information for families. This is really hard for families and really hard for the kids, and just having a group to, if they don't want to say, want to join as like a peer community, but at least it's a lot of good information online as well.
Yeah. Great. We're learning, and I think it's part of it is really being open to this being very real, right? As step number one, and then really trying to guide families to the best place that understands the protocols. And a quick question, and then we're going to wrap up. I want to ask you, Erika, about the Recover study. But a quick question that came in about confirming a diagnosis of long COVID if the PCR is negative. How are we going to get that confirmation? Are we at all going to get that confirmation, Melissa?
No, I mean, I think so. Again, we part of Recover research, like we do antibody testing, but we're actually using it more for the children who our family thinks are uninfected and says, like, my kid never had COVID. There are a lot of them that we are testing, and sure enough, the kid did have COVID, because they have the N, and mentioned in the Q&A is that they have the obviously the spike protein. So the S antibody you can get from vaccination, the N antibody you really can only, nucleocapsid antibody you can only get if you've been infected. So it really is more based on the WHO criteria, which is sort of having had, COVID-like illness, when there was COVID in the community. And then there are a lot of families who do say, like, yes, I was antigen positive, was PCR positive, et cetera.
But having had a COVID-like illness being the criteria, not necessarily having tested positive on a PCR.
Right. And I know there was a question in the chat. And I just want to make sure we get to about, like, could this just, the mental health changes just be sort of in adolescent mental health? The best studies, and again, that's where Erika's gonna tell you what cover, you're comparing a population that was infected versus the uninfected, which is why I want to bring this up now. So you're looking at symptoms in kids who had infection and prolonged symptoms, and you're looking at symptoms that are prolonged in kids who are uninfected, and you're comparing those two. And so that's how we're teasing apart what we think some of the symptoms are, or constellation of symptoms, as Josh said, it looks different in different people. That is going to be what long COVID, most likely looks like.
And it is worth pointing out that it certainly could be that certain mental health issues could be risk factors for certain presentations of long COVID. So but that doesn't mean the leap not to make is, oh, all of this is just in their head. It all looks differently in different people, and there can be some cause that is neurocognitive, and then there also can be some effects that are neurocognitive, and that's really the way as what is attributable to having had the virus, right? And then from there, deciding where to go from there.
Yeah. Erika, tell us about the Recover study, because it is really exciting. You are all intimately involved, and I want to make sure that we hear about it. So tell us.
Yes, so we represent Columbia amongst many other sites across the United States. The Recover study, as I said earlier, the NIH recognized early on that this could be a potential real health crisis for years to come if we didn't address define and determine the incidence, prevalence, and really trajectories of long COVID. And so they invested in this Recover research trial, which is an interesting design, which I'll tell you in a moment, but really aimed at, number one, defining what is long COVID. We really, to date, hadn't known what this entity was, even if there are other viruses that linger. This was unique, and we needed to learn more about that. What is the incidence of it? How often is it happening? And then what are the clinical symptoms? What are the phenotypes? The variety of symptoms, many of which we talked about, are different. Not every child or adolescent or infant is the same. And what do these presentations look like? And what, even subclinically, what organs may or may not be involved, particular child? And then to Josh's point, what are the biologic mechanisms of the disease that are going to inform how we treat this someday, or how we prevent it someday? So these are the key questions. And again, going back to what are the risk factors and what are the resiliency factors that are going to impact who is more prone to get long COVID or not. So a lot of questions to be answered. So as I said, this is a large endeavor aimed at enrolling over 15,000 in our pediatric cohort, newborns through age 25 years across the country in a variety of different cohorts. It is, in terms of design, what we call an ambidirectional, part prospective, part retrospective study, with these sort of nested cohorts within it, to look, to Melissa's point, at comparing those who have been infected acutely, those who had a past history of being infected, and those who are uninfected, who may actually during the course of the study develop long COVID, and that's where we might learn more about the incidence. And by comparing these different populations and doing a lot of testing, which I'll tell you about in a second, we hope to answer many of the questions. And so the design is such, just quickly give you a bird's eye view, is tiered, okay? So we call it tier 1, our light touch or mostly remote testing to the largest number of patients in these categories. And this can be done, this is a lot of surveys, questionnaires that are done remotely off-site, as well as the saliva and blood spot blood kit so that we can confirm or that they had the diagnosis or not, and also store a sample for future DNA and other testing. The second tier level, subset of these patients, will go for more advanced testing, and they will do part at home. Again, a lot of surveys about symptoms and across the many, different domains, neurocognitive symptoms, psychological symptoms,
Yes.
different organ systems symptoms. And then those patients will come on site and have light touch testing. So spirometry, looking at their pulmonary function test, looking at electrocardiogram, getting vitals, looking at that, the test I mentioned earlier, the 10-minute stand test, looking for any signs of autonomic dysfunction. And then finally, a subgroup of them will ultimately go on to this tier 3 level testing. And that's going to really get to, I'm a cardiologist, the heart of the matter. We're going to look at more intense testing. And for example, that's where cardiopulmonary exercise testing will come in. And to Melissa's point about, potentially we need to be careful. We need to screen patients even before we do that to make sure they're not at risk or already having signs of post-exertional malaise. We don't want to exacerbate it. But along with that, they may have echocardiogram, neurocognitive testing, MRI, EKG, EEG as well, and other intensive survey-based testing. So we will bring them on site to do that testing. And that is just, I want to say that we're still accepting patients who have had
a quick question for you.
yes,
Yes.
we have long COVID. I know, and Melissa mentioned earlier, we absolutely are still accepting patients into the trial. And I do believe this, I know it's really is landmark in the scope and in what we'll be able to discover, I hope, so that we can learn, again, about how to intervene and hopefully treat and prevent. So that's a nutshell. It's quite, I wanted to give a shout out to Melissa.
And if you have, if you have patients who you think of prolonged symptoms, it's important to know that RECOVER is an observational study. They have not started pediatric clinical trials yet as part of RECOVER. They're adult clinical trials, but not pediatric. But we definitely want to enroll more patients. So if you have a patient, even if you haven't diagnosed with long COVID, but they have prolonged symptoms after COVID, probably the best thing to do is just, I guess, email. I don't know, we should email me or email Edith or where, I don't know where they can find our contact information. But email any of us and we can help with enrolling.
And we can also, if it's helpful, send a link to the RECOVER study when we send the recap for this webinar. This webinar is going to be available on YouTube, on the Columbia Children's Health YouTube. And we always send a follow-up email after if you registered for us, so we could definitely send a link.
There was also a question about where to refer, how to refer patients. I answered the question in the Q&A. So I don't know if people want to look there or you want me to read it out, but
please read it out, Melissa.
Yeah. So there's a question sort of okay, well, how I have a patient who, I think needs to see a specialist, how do I make that happen? So NYP or New York Presbyterian has put together a long COVID program, and you could just email and answer to the Q&A longcovid@nyp.org. And there's this amazing patient navigator who then can help connect up. That's actually for adult patients and pediatric patients. So she does it all. And if it's a pediatric patient, she'll reach out to us and we'll help connect the family up to the right specialist based on kind of what body systems are involved. And if it's for an adult patient, then, they have adult people, they can connect people who are adults.
Perfect. We have a couple of minutes. Maybe we can do some rapid fire answers to some of the questions that came in, because we do have a lot of questions that came in right at the end. Let's try. So Josh, going to you first. Any evidence of development of lymphoid malignancies in long COVID yet?
There have been lots of anecdotes, but I'm not sure that systemically we see that, and definitely not there have been anecdotes that can end up happening, and it could well be the same mechanism that you're having a difficult time defending against the malignancy in the same way you have a difficult time defending against mono or whatever else it is. But that's theoretical, right?
Yeah. And then any place in the reactivation of certain herpes viruses, like any place in given acyclovir, I guess. Yeah.
that is so broadly, with respect to treatment of COVID, I think it's probably good to put that in there. So yes, there have been folks who have suggested that going on antivirals right when it happens is worth it, including right when, let's say, if you have a reactivation, that it happens going on earlier. Doing it later doesn't tend to do very much. It really is the kind of thing where you want to catch it early on in the course. I think it's probably not relevant for too many people who've had long COVID for 3 or 4 months. There's not much relevance for that. So many of the other things, it's the same story, like IVIG and like immune suppressants and lots of other things. There probably will be some larger studies. There are plenty of anecdotes that everything works. And then, but when push really comes to shove, there's not much evidence that anything works.
Thank you for that framing. Erika, when someone has had MIS-C, can they still get a COVID vaccine after they have recovered?
After they've recovered, yeah. I don't want to give it immediately afterwards, but sure, several months later, yes.
Great. Melissa, if someone has long COVID right now and they're due for other childhood immunizations, would you give them?
Yes, I think there's not a reason right now that you'd want it. And again, we wouldn't want them to get any of these other childhood illnesses, right? That's gonna, obviously gonna make them, I would imagine it will make them actually feel much worse. And so there's no reason to be holding vaccinations.
Yeah, perfect. And then there's one more question, and then I think we're gonna have to wrap up, but resources will be sent. I promise to everyone who registered in the webinar will be available. But there was a question that came in about COVID-19 vaccines in children impacting future possibility of getting pregnant. And at this point, we know with certainty that COVID-19 vaccines do not have a negative impact on fertility. You can absolutely get pregnant later on in life if you've been vaccinated against COVID-19 vaccine. Remember, it's always the protection that lingers, not the vaccine itself. Okay.
And just to point out that actually non-vaccinated people were less fertile than vaccinated people.
Thank you for that, Josh. What a better way to end the evening than with that framing. Thank you all so much. Thank you to our panelists. You are all amazing, busy clinicians, researchers. So we really appreciate your time. Thank you to everyone that joined. Please follow us on social so you never miss an update on things that are coming up and other webinars. April 17th, we're going to talk about the care of formerly premature infants. May 14th, we're going to be talking about asthma. We're so excited. We have amazing people. And we'll be sending out a link to the recording. And thank you all so much for joining. Sorry we went 2 minutes over. Have a good evening.
Yeah.